Thank you so much, Dr. Suyash, for joining us on a podcast at Dawdle, who have led innovations at various levels in the healthcare segment. I welcome you, sir. And to start with, as we do with all our guests, if you could take 2-3 minutes and take us through your journey so far.
Thank you, Rishikesh. This is a very interesting platform, and I am truly honored to be here and for your invitation. So, I'll just tell you briefly about myself. I am a practicing gynecologist in the city of Jalgaon, which is in North Maharashtra. I work in a family owned hospital which was started by my father, Naval Multi Speciality Hospital. This is the sixth version of our hospital here now, which we built about 5 years back. I am working here mainly in the area of minimally invasive surgery in gynecology. Okay, I'm more into a subspecialty of gynecology, that is kind of laparoscopic surgery, hysteroscopic surgery, all minimal access surgeries. And starting with that, all the surgical approaches in gynecology, we kind of went into it into a deeper levels and went ahead with kind of newer procedures to advance our skills as well as to offer more and more or the best possible ways of doing minimal access surgeries. So in that effort, we started doing V nodes procedures in India in gynecology. This was something which was not being done before 2019 in India when we started. We were very happy to introduce it, although we are in a tier 3 city, so to say. But I mean, we would start wherever we are, right? And thanks to my father for laying such a nice platform so that I can do such things in my institute, in our hospital in this city, where we have not only established this procedure for patients, now crossing more than 1,000 procedures, but we have also established a training center for this so that more and more gynecologists can learn and can give such kind of a virtually scarless surgical care for their patients. So right now, every 3-4 months we conduct such courses, and people from entire Southeast Asia attend our courses. And having done that, we also ventured into other microinvasive procedures like non-surgical treatment of fibroids or adenomyosis or endometrial pathologies, which are other diseases of uterus, okay, where females having problems with severe pain during menses, excessive bleeding, all these things can be covered with novel technologies which are more successful than medical management and do not require a very invasive surgery. So for patients, for women who are working especially, it's quite good because the recovery is very fast. So this is something of my background in terms of my clinical work. I also am very interested in innovation because what happens as a surgeon, as you practice more and more, you get these ideas that how I can improve my surgery, how I can enhance, either to make the procedure easier,
Yes.
more approachable, to improve patient outcome, or to come up with a completely new idea which can have a bigger impact. Fortunately, I have had some ideas and I have been successful in some innovations, especially in working with the industry, medical device companies. So, in collaboration, in working with the engineers and innovators and researchers, we have been able to produce some products which are now impacting many, many lives. So, that is something which is also I do and I'm interested in doing, and I continue to do so. Also, I work as a part-time consultant for medical device companies for certain projects. So I think that's it.
That was a great introduction,
Yeah.
Dr. Suyash. So, the first topic that we'd like to pick your mind on is that you have pioneered oat surgery in India, NOTES. And from your perspective, what are the biggest limitations of today's laparoscopic and endoscopic tools? And where do you see the most room for innovation?
See, uh, to tell you that in gynecology, we started with the vaginal route. Actually, it's the oldest route of surgery in gynecologic surgery.
Yes.
So the natural orifice surgery is actually older than transabdominal surgery in gynecology.
Yes.
This was the era when there were no principles of asepsis. Asepsis is something which washing hands before surgery. So this was the era when washing hands before eating food was also did not exist. The knowledge was so poor about these things, about hygiene, that this was the era. Okay, but then when the era of asepsis started, we had sort of moved on to abdominal surgery by that time.
Yes.
Yeah. So we had moved on to the abdominal surgery by that time. And from abdominal surgery, as you know, which is like making a big cut on the abdomen, and all sorts of surgery, whether gynecology, whether general surgery, whether cancer surgery, are done in that fashion. And obviously, it was a very invasive surgery. It had problems like excessive bleeding, more chances of infection, longer recovery times, and other complications like, these incisions can get hernia later on. So, all these were the problems with open surgery, but that was the only way. And then came the entire era with, advances in using lenses and telescopes. And from telescope came laparoscope. So, with the advent of laparoscope, and good cameras and monitors, all these things came together to make something known as minimally invasive surgery, which we know today as laparoscopy. And the next level of laparoscopy is now robotic surgery. Okay? So this has all what has been happening. Now, with this advancement of laparoscopy, robotic surgery, cameras, high definition, 4K, and everything, it was a good time to revisit the vaginal surgery, the age old traditional vaginal surgery, which did not involve any cameras, which did not involve any laparoscope. So, bringing all this technology to vaginal route has revolutionized the vaginal surgery. So, it is not for the limitation of laparoscopic surgery or robotic surgery that we are doing it. It is mainly because it's a less invasive surgery. Because even in laparoscopy, we are making keyholes, small, tiny holes on the abdomen. Same goes for robotic surgery. So the goal of minimally invasive surgery is to be minimally invasive. So from big scar, we came to small scars, and from small scars to no scars on the abdomen. So that is progress, right? So that is how we have been doing. And fortunately, today, the instrumentation, the technology, the industry has innovated enough that VNotes has become a feasible approach, at least for gynecology. Okay. For general surgery, I mean, to do appendix surgeries, to do gallbladder surgeries, or to do any other major surgeries like bariatric surgery or urology surgeries for kidney, I would say that VNotes has to evolve even further, especially with robotics. And probably that has already started to happen. So I think the future of surgery is going in this way. We are becoming more and more minimally invasive. Plus, there are more and more micro-invasive procedures also coming up, which are not which are less surgical or non-surgical, so to say. Even when we talk about minimally invasive, it is minimally invasive for the external part of the body, that is the abdomen. Okay, mainly. But inside, you are doing all the cutting and all the surgeries, right? So now we are also moving slowly towards an era where we are trying to treat the inner diseases, especially the solid organ diseases, without cutting them or without opening them or removing them. That is by either burning them or ablating them in some way so that we don't have to remove them. Okay. So this has been applied. It's known as ablation. It has been applied for liver cancer, for bone tumors, for any solid organ tumor, kidney tumors, and same thing we are doing in gynecology.
Got it.
So that is something where we have all kinds of technologies like high intensity focus ultrasound. That is ultrasound. You must have heard about ultrasound. So these ultrasound, normal ultrasound for diagnosis is, very few amount of sound waves which are giving you this picture. But very large amount of sound waves, if they are concentrated on one point, will create heat. And with that heat, you can burn something inside without touching the patient. So it is focused ultrasound. So that is one way. Or in conjunction with laparoscopy, if you are doing some minimally invasive surgery, in conjunction with that, you want to do a procedure like ablation. That is, without cutting the organ, you want to burn some disease inside, then you can do either microwave ablation, that is a needle which will throw microwave energy, will go inside and burn that disease. Same goes with radio frequency. The radio frequency needle will go inside, will burn the disease. So all these are kinds of newer surgical procedures which are even less invasive. Micro-invasive, not only for abdomen, but also for the organ on which you are operating.
This is very interesting. And I know that you have introduced these non-surgical processes like ablation you're talking about in gynecology. And would you like to talk a little bit more about such treatments?
Yeah. See, in gynecology, uterus is also a solid organ, right? So ablation really started from the liver cancer procedures. Like in liver, if the hepatocellular carcinoma or the liver carcinoma, if it is diagnosed very early, when it is less than 2 centimeters, about 1 centimeters, then instead of doing the entire cancer surgery of opening the abdomen, reaching the liver, removing that part of the liver, you can obviously understand that it is going to have morbidity and its own course of recovery. Here, instead of doing that, under just ultrasonography guidance, ultrasonography probe is just put on the body. Okay, it does not go inside. It's non-traumatic. With the guidance of that ultrasonography picture, the radiologist or the surgeon inserts this needle, either of microwave or radio frequency, which goes into that tumor and burns that entire tumor and even some amount of normal tissue also. Because in oncosurgery, we need margin. Okay, we need to burn the entire disease. Don't leave cancer behind. That is the principle. So that became quite successful. They had very good results. And from a major surgery to a microinvasive procedure where the patient is going home on the same day or next day, it's a kind of a revolutionary difference. Okay. They are miles apart in terms of recovery. So with the success of that, it was obvious that this technology can be used in other solid organs. And so we have now ablation techniques for thyroid glands, for, abnormal thyroid tumors in the thyroid gland, for kidney tumors, for bone tumors, for breast. And then obviously in gynecology, we started it for uterine diseases. It was already quite prevalent in China and Korea and Taiwan. And we kind of introduced it in India because, again, for uterine diseases, when we talk, fibroid and adenomyosis are two of very common pathologies which we see in women. You would not believe when I say that every 4 women in 10 women will suffer from adenomyosis or fibroid at least once in their lifetime. That is how common it is. Okay. And at least 50% of them will have symptoms significant enough that they need treatment. And for these things, for these pathologies, fibroid and adenomyosis, medical management has got a limited role because it cannot remove the disease from its roots, and then the surgery is the only other option.
Yes.
So even when we talk about minimally invasive surgery for these things, like to remove fibroid or to remove adenomyosis, it's minimally invasive for the abdomen. You are making small holes on the abdomen, but on the uterus, you are making the same big cut to remove the tumor, and then you repair the uterus. Okay. And then what happens is that with a bigger incision, with a bigger cut, obviously, again, the problems of bleeding, chances of infection, wound healing, all these things will be there.
Yes.
And when this patient will become pregnant later on, in pregnancy, the uterus expands and
Yes.
you have made this scar,
Yes.
which that part of the uterus will not be as strong as the rest of the uterus. So sometimes this scar may give way during pregnancy as the uterus is growing. So with these kind of new procedures where you are just sticking a needle with a point with a small hole in this organ, you are burning the disease, maybe not completely, but your goal is to reduce the disease. Okay. If you do it in this way, then you are saving a big scar on the uterus. So that is the idea. And therefore, we introduced this in 2021, and it has been quite successful in reducing the symptoms of the patient in terms of the pain during the menstruation, during the bleeding, and even reducing the volume of bleeding. So, another benefit of doing these things is that ultimately you are reducing the number of hysterectomies.
Yes.
See, you might have heard, I don't know, in newspapers, especially in last year, Supreme Court, you must have read in newspapers that Supreme Court has given a guideline or a directive to all the state authorities to reduce the number of hysterectomies, especially in patients less than 40 years. So once these things will come into play, and by law, we'll have to reduce the number of hysterectomies that are being performed. I'm not saying that hysterectomy is a bad surgery. Hysterectomy should be done only when it is needed. So for some patients, that is the only option for treatment.
Yes.
But with these treatments coming in, the newer treatments coming in, which are slightly better than medical treatment,
Yes.
probably you can save hysterectomies, you can save many uteruses, and the patients can get relief from a smaller procedure with lesser morbidity.
And is it safe? Like there are no other effects of using these radiations?
See, of course, every procedure or every tool or every energy we say will have its own problems or complications. See, it is like a knife. Now, if you give a knife to a chef, he will use it for a good purpose of making food. But if you give knife to some antisocial element, he will
Yes.
use it for bad purposes. So it is not that the device or the technology is wrong. It is the person who is using it. So if that's why I always hammer on the fact that we need to train people in a systematic fashion so that they understand the technology, they understand the technique, they understand the limitations, they understand the advantages and complications. Only then you can proceed with a new procedure, introducing it for your patient. One has to be well informed and well trained.
This was very insightful, actually. And now, we will kind of take you to, since you have been running a specialty surgical center, what role do you think these hospital information systems and EMRs are playing in ensuring seamless patient care, especially in the women's health segment?
See, it was always important, and in today's era, it is very important that we keep our medical records up to date. And maintaining medical records until a few years back was a complete manual work. Today, more and more hospitals, almost every hospital is having an electronic EMR or a computerized EMR, okay, which is very important. But even this requires manual input, right? Ultimately, it is just the way you are storing it has changed. But the real revolution is coming now, where this will be done with the help of AI. Okay. And AI is revolutionizing all the steps of EMR. That is how you record it, how you store it, and how you retrieve the data. Right. For example, I'll give you an example of to input the medical record data. You can take the history of patient in your OPD if you are a doctor using a voice tool. There is an Indian startup called Augmented. Okay. So they have made this voice tool where you are just talking to the patient, you are taking the history, and you are telling the software all the notes and everything. And this software understands all the medical terms. And it understands which part is complaints, which part is your examination finding, which part. So even if you make some mistake over there, it will generally create a structured report of the entire data which you have taken the history from the patient. Yes. And you can do some tweaks in that, but more or less, if it is even 95% accurate, your 95% workload has gone down. Yes. Okay. And those 5% you can just kind of evaluate it and then put in the prompt for final storage. And then when this is being stored, like there are directives that your data should be recorded for this particular kind of cases for 10 years, for other kind of cases for 20 years. Yes. Now, when we had physical records, we were able to do it that, okay, this is more than 20 years old record, we can discard it now. Legally, it's not mandatory for us to do that. Okay. Yes. So with AI, we can simply give that prompt that, or it can be in its system that the data of only 20 years is maintained. Any data older than that can be deleted automatically. Okay. So all these things are there. And then again, for retrieval, data retrieval, if you give a particular prompt, like for example, maybe you are doing a research on fibroid, you want to do a retrospective study, and you want to retrieve the data from your EMR. You just give a prompt that I want the data from all the patients who underwent fibroid surgery by laparoscopy, and you immediately get that data. And the AI will become so smart that it will even prepare your Excel sheet and master chart for your study from that data. Your significant workload has gone down.
Doctor, one of the things is that post-surgery care is a space where we see there's a lot of gaps for hospitals, no regular follow-ups, and, post-surgery, it gets very difficult to track the patients also. Do you see any technology coming in this space, which is helping hospitals keep a track of the patients post-surgery?
Yeah, so see, many softwares even today allow the institutes as well as the patients to receive a prompt on their phones, or that today is your follow-up, or in 1 week your follow-up is coming on this date. So that is already there, that exists. And I think for post-surgical care, it can be again further optimized by using artificial intelligence, that the AI knows all the preoperative status of the patient. You can even we can talk more in detail about this maybe later on, but you can store the entire data of the patient about what surgery the patient went through, or what medical course the patient went through during the admission period. Okay. And using this data, okay, and having the record of thousands and lakhs and millions of cases similar to this, the AI can predict that what would be the post-operative course of this patient, in terms of what is the likelihood of recovery of this patient in 2 days, 3 days, 4 days, then what are the chances of post-operative complications this patient can have, when should be the follow-up of this patient. Okay. So see, I'm not saying that surgeons today are not doing this well. They are doing this well. But when you compare that data and when you have the evaluation power of lakhs and millions of cases, then maybe your accuracy is slightly more. So, or you might come up. See, AI as of today is not a replacement for any doctors or surgeons.
Yes.
It's an assistant. It's
Yes.
a help. So if it is giving you some information which you might miss in some cases, so it's good. There's nothing wrong in that. I think so. All these tools will come in. All these AI tools will come for pre-operative phase, for intraoperative phase, for post-operative phase. In every part, they will be integrated in the systems of hospitals and how hospitals operate.
Doctor, do you think that surgeons are ready to trust AI guidance during live procedures, or will adoption take more time? And what can be done?
See, something which is very interesting and also scary for surgeons, I don't know, that is coming is autonomous surgery. But that is, I don't know how long it will take for that. So, surgeons may or may not be scared of that. But what surgeons are definitely not scared of is AI being an assistant, a good assistant.
Yes.
Okay. Because if any kind of AI technology or tool or software is enabling you to make a better diagnosis, to make a better surgical plan, to help in an effective patient counseling, and intraoperatively also it is being a good assistant. You are the surgeon, but you have one of the best possible assistants. What's wrong with that?
Yes.
It will only improve your performance. It will only improve your outcome. And of course, all these AI tools will have to undergo before they enter your operating room, they will have to undergo regulation from
Yes.
all the concerned authorities. So these would be tried and tested tools with clear evidence that they help improve the surgical outcome for XYZ cases or patients.
Yes. But what we see is that, and I'm talking in very layman terms, is that, doctors see a lot of cases on a day-to-day basis, and that basically evolve their experience. Like, it's usually told that doctors who have seen a lot of different cases, they are better doctors. Do you think this AI coming in can also make a doctor biased, or maybe thinking like, this information is coming from AI, but I am thinking like this, there is a difference, but ultimately going on to trust what AI is telling? Do you think such kind of scenario can also develop?
I think, if you look at any technology, when it's new, it is taken with a pinch of salt. In fact, not just with a pinch of salt, it is first criticized. It is ridiculed. Then, when it is obvious that it has some benefits, then it is accepted. But then it will still have because when it's first generation, second generation, it will have its own curve of development. And it's not perfect initially. It will make mistakes. It will have its own pitfalls. So, initially, when we incorporate these technologies, we'll have to be more vigilant.
Yes.
And we'll have to be suspicious about its accuracy. We have to cross check it in multiple ways. It will be important in both ways. One is to verify, and second is to build our trust.
Yes.
And once we have its trust, another good point is that suppose there is an expert and there is a novice. AI tool as an assistant is bringing in information and experience to even a novice. So it is democratizing the information. If somebody has spent 40 years, he has significant edge in terms of experience and knowledge over a novice. And with AI, maybe he is not the same expert, but at least he has some information and some insight and some assistant tool at his hand to reduce that gap.
Yes.
So this is good for the patient. That patient lands up with any doctor, even who is a novice or who is a beginner, has that information. So maybe he is able to make better decisions. So it reduces the gap between the expert and a beginner.
Got it. It kind of democratizes,
Exactly.
Now, talking about prevention and early detection, especially in case of women health, what role do you see the new diagnostic devices, wearables, or home-based screening tools have in empowering women's health?
Yeah, of course they have. Like for women's health, I have been looking into what smart devices could be made. This often happens to me that I think of some idea, I'll write it down, and I'll even make some diagrams. And when I do a patent search on Google, I find that somebody has already filed this patent. And of course, because the idea which you get, somebody else can also get who is simply thinking on the same line. So this happened to me when I was trying to make a smart menstrual cup. Okay, smart menstrual cup is what? Now there is a menstrual cup. Menstrual cup is a device where a silicone cup is inserted in the vagina where the blood will be collecting. And once, it can be thrown away, it can be cleaned and reinserted. So that way it is cost effective, it's more hygienic, XYZ, environmentally better. So all the benefits, okay? But the adoption is surprisingly poor. Okay, it's not See, companies are not making so much profit selling the
Cups.
reusable cups than
Yes.
the disposable
Sanitary pads. Yeah.
sanitary pads.
Yes.
So there is a bias over there, and also there is poor information, poor awareness. Maybe even we doctors are slightly failing on our part to dispense this information effectively. But what the idea was that by making this device smart, it can give you information that whether the patient is having any pathology. The function of a menstrual cup was just to collect the blood and give a hygienic solution for that. If it can measure the amount of blood,
Yes.
it can understand the color of the blood, and with that, if it can correlate to with some pathologies, and all these things. So
Yes.
with couple of sensors, it can be done very easily, and it can be connected to your phone with an app, and
Yes.
you have the data. It becomes your menstrual calendar. It hints you that you might be having some pathology, you should visit a doctor, all these things. So this is one of the wearable devices. I have seen that the whoever filed the patent, now there are a couple of startups on this idea and device,
Yes.
and they're on public funding and XYZ. But
Mm.
so this is something that is happening. Then again, smart intrauterine devices, there is another thing, because some devices go inside the uterus to
Yes.
help in contraception or to help in reducing bleeding and pain and all these diseases, adenomyosis, to control these diseases. So again, if it is made smart, that it can again have some diagnostic value in some pathologies, or it can prevent its own complication, that if it gets dislodged in a position where it should not be, then
Yes.
it can give an indication that I am sitting in a wrong position, please visit your doctor, either get it removed or get it corrected.
Yes.
So these are the things which I can think of in women's health. And then in general, in medicines, there are many wearable devices, and I think that segment is going to explode. And this is the point where the consumer electronics is overlapping with the medtech, right?
Yes.
So it's very interesting. But I think the consumer electronics will remain on the surface, right? As soon as it becomes slightly invasive or partially invasive, then it becomes more of a medtech device.
Got it. And now I will take your attention towards VNotes Academy, where you train the other surgeons, and would like to take your views on the role of AR, VR, simulation, and digital training platforms in building surgical skills. And also from the perspective of hospitals, or the medical colleges, do you believe that the next generation of surgeons will rely more on simulation based learning than traditional apprenticeship models?
Yeah, this is automatically going to happen. It's already happening for two reasons. One is the simulators are becoming better.
Hmm.
There are high fidelity models which can mimic the anatomy in such a realistic way that you can almost mimic all the surgical steps which are essential for your learning. Okay. And again, even in terms of technology side, the entire user experience in simulation is such that more and more such devices are coming where the trainee feels that this feels like a natural surgery. Okay. And there were the first generation of simulation devices where, things where the animated surgery was there and you are moving the instrument and something is happening inside. Now the haptics is being added to that. Now the AI is being added to that, which is evaluating your performance, which is which is credentializing you, telling you whether you are up to the mark or not, how close you are to an expert, and where you need improvement, or all these things. And so evaluation is becoming better. So this is ultimately going to help in two ways. One is it is safer way to teach the surgeons, because if you are learning on patients, it can be a ethically debatable topic. So more and more guidelines are coming where you have to use, or you should be using, simulation if available. And just to tell you, with VNotes Academy, we have been innovating such devices. Like
Yeah.
we have recently made a endo trainer, or a smart endo trainer, where it is not just simply sticking your laparoscopic instruments inside and just exercising with some rings or some balls and things like that. But we have actually created a a dummy abdomen, a dummy internal anatomy, a dummy uterus, ovaries, tubes, entire pelvic anatomy, where you can actually do the entire surgery of hysterectomy. Okay. Now, this particular, we call it lapis venotes. Okay. Lapis is the laparoscopy part. Venotes is, of course, the transvaginal endoscopic part. And you can learn all kinds of hysterectomies with this endotrainer simulator, you can say. it has these high fidelity models, artificial abdomen which inflates just like in laparoscopy in a actual patient, where you put in gas in the abdomen inflates. And then you can either do laparoscopy or do robotics, practicing robotics, or you can practice vaginal surgery or V-node surgery. So all in all training platform for gynecological surgeries. So this is something. And then using AR and VR is like uh, what I did for some some cases is that I recorded a standard case in a 360 camera and creating a 360 video.
Yes.
When I upload this on a 360 viewing platforms like VR headsets, whoever is wearing or whichever trainee is wearing this VR headset feels that he's in the center of the surgery, right where the surgeon is, and you can see all the hand movements of the surgeon as well as you can see the surgery on the surgical screen. So it's a different perspective. You can look from the surgeon's point of view and learn. So that is one way we have done it. There are some companies who are making this entire simulation of the entire OR.
Yes.
Like you walk into the OR and there is entire, there is a dummy patient, there is an instrument trolley, there are nurses, there is surgical staff, and you are doing this procedure. So entire scenario is created. Okay. The only problem with these things is that they don't have haptics now. So unless the surgery is not just about doing the procedure visually, but it is also about feeling. That's why I am more into combining these high fidelity models with augmented reality. There is recently one company in, I think from UK, who have combined these kind of high fidelity models. Like the organ on which you are operating is the model action, which is made up of silicon or something similar, and around it you are viewing it through special XR glasses, and augmented reality is created.
Yes.
Like uh, around this model, the surgical scenario is created. So even if you are operating on this model, you feel that you are doing some surgery. So it's a enhanced user experience, and it I think it trains you better in terms of learning. And we have also kind of combined the augmented reality glasses, not just in training but also in the surgery, where you can visualize your surgical screen,
Yes.
make it bigger, and ergonomically it is better. Because see, when we are doing laparoscopic surgery or any endoscopic surgery, you have surgical monitors which are placed somewhere in the OR. Okay.
Yes.
And the patient is in one position. Okay. And sometimes you have to operate in different quadrants of that patient. So as you shift the quadrant, either you have to move that surgical trolley, or the monitor has to be placed, or you need that many number of monitors in the OR, so that when you turn this side there is a monitor there, when you turn this side there is a monitor there. Instead of that, you can have XR glass, augmented reality glass, which you do not lose the sight of your OR. You are completely oriented in OR, but there is a large screen in front of you, and no matter where you move your neck, the screen is always in front of you. So that way your sight from the surgical point of view is not changing even for a second. And plus, in addition to that, you can have multiple screens where you can place other diagnostic information of your patient, like MRI of the patient, X-ray of the patient, USG of the patient, and you are operating. So if you need any data from that, it is right there. You don't have to ask for it. So these are the various ways. And then, of course, augmented reality is being applied to the intraoperative situations where, for example, you are doing a surgery. The AI is helping recognize some small part, anatomical part, which is very important, which you should identify, and it is highlighting.
Okay.
So you cannot miss. Okay. So these things, these applications are already coming. We have some of these applications already available in gynecology. Like, for example, there is a uterus and there are multiple fibroids. Some fibroids are obviously, there is going to be a big bulge on the uterus. You can see them very obviously, and you know how and when to remove them. But some fibroids are deep seated.
Yes.
They are inside. So you want to know where I'm supposed to make the incision. So normally how we do it, the surgeon has to understand it three-dimensionally and visualize it. And from the MRI or USG, you need to know where that fibroid might be, and then you take the incision. But with this kind of AI augmented reality, it will be highlighted like a kind of a real-time color coding annotation on that tumor. And then
Yes.
you know that this red color ball, which I can see in this organ at this depth, is this pathology, and I can take incision here with accuracy.
This is very helpful. Like, it's very helpful for the doctors. Now, at last, I've got a question. Is that, since you have you're not only a doctor, you have kind of founded multiple healthcare ventures, and you have tried blending surgery, education, and innovation into one. Now, from a founder's lens, like, what are the biggest challenges in adopting new surgical technologies in India?
See, I'll tell you a big difference between the consumer technology and medical technologies. The adopters of consumer technology is general public, okay, like your mobile phone, okay. Any new thing, like if somebody adds the sixth camera here, people will rush to buy that.
Yes.
So the adoption, there is no hindrance to this kind of adoption. All you need to do is innovate, apply, bring the technology to the market. But what happens in medtech is that there are significant, serious regulations uh, which which are there at every step. First of all, innovation itself is difficult. Secondly, your success that it will become a real device and come to the market is less than 2% or maybe less than 3%. And even if you have the prototype ready, you have a working formulation, you have proof of concept, you have to submit it to the regulation, and regulatory authority should now clear it, and then it comes to the market. And then now another big hurdle is the surgeons or doctors themselves, and they are absolutely right in being suspicious about any new device, any new technology, because they want to play it safe, right? Ultimately, it's for patients safe, that unless and until I understand that this is something, even though it is new, it will be really helpful. It will not have some weird new complications. And because it's also a significant risk whenever you are doing something new, right? So this hurdle, therefore, it takes a long time to a medtech device to come in there. And the only problem is that nowadays the things are moving so fast that the entire thing which was innovated in 2020, by the time it comes out in 2025,
Yes.
either the things have moved on or there is some other competitor who has come up with something which makes your invention obsolete.
Yes.
So this is the difficult part of it. But for every difficult problem, see, it's if you are doing something very difficult or very hard, and if you crack it,
Yes.
then there is no one to stop. Then you have few competitors.
Yes.
Because if something is very difficult to do, you will always have few competitors. All you need to do is to stay put and do that, and someday you will succeed.
Got it. Thank you so much, doctor. I think that this session was very insightful. Will be helpful to so many doctors and medical leaders who will be watching this podcast. And we again thank you for taking out time and sharing your insights with us.
Thank you so much, Rishikesh. I enjoyed this conversation, and I hope I was helpful. Thank you.
I was also a good listener. I loved, the things that you're talking about.
Thank you.